Welcome everybody, good afternoon. Welcome to our CEO Desktop Chat. We want to give you a few reminders of the ground rules. We will have a brief presentation by CEO Finley and also some comments from our newest panelist, Tangerine Brigham, our Chief Administration Officer for Population Health. And then we will take your questions. Please be reminded to click on the Q&A icon at the bottom of the screen and submit your questions there. We will try to answer as many of those as we can as we proceed to throughout today's chat. So welcome, and if we can begin with introductions. I am Terry Lightfoot, Director of Public Affairs and Community Engagement for Alameda Health System.
I'm Janet McInnes. I'm the Chief Nurse Executive, Chief Administrative Officer for Acute Care.
I'm Tangerine Brigham. I'm the Chief Administrative Officer for Population Health.
Hi there, good afternoon. Conver Hussein, Chief Quality Officer.
Hi, I'm Rachel Baden. I'm the Chair of Medicine here at Alameda Health System on this panel in my capacity as an infectious disease physician.
And I'm Tony Redmond, the Chief Human Resources Officer.
All right. Del Vecchio, take it away.
Great. Thank you, Terry, and thank you to my fellow panelists. Good afternoon, everyone. It is so great to be back with you after taking a week off. I thank everybody for tuning in today, and thank you for your indulgence last week. We had an important last-minute meeting with the Secretary of Health for the state of California to really have the opportunity to share the space with fellow safety net organization leaders to talk about some of our experiences, our challenges thus far, some of the things that have gone well in terms of our collaborations with our local partners, with the state, and in some cases the federal government as well, but also ongoing challenges and needs on the horizon, both for our organizations and the communities we serve. So I appreciate that indulgence, and again, great to be back with you this week. Now, within the last several weeks, obviously, there's been a lot of difficulty, but no less, I am really proud of how we continue to come together to remain focused on our mission of caring, healing, teaching, and serving all. And I want to thank all of you for supporting each other, for listening to one another, and having very important and often difficult conversations with your families, your friends, and your colleagues. In these times of confusion, due to differing rules and decisions happening at all levels of our government, we want to reaffirm our commitment to health equity and diversity and inclusion for all of the communities that we serve, regardless of their sexual orientation, vulnerabilities, or languages they speak. We want those who we serve to understand that we stand by our unwavering promise and our mission, and we will continue to serve all with high quality, culturally and linguistically appropriate care that is accessible to all. Our commitment to health equity, diversity, and inclusion will not waver, as many of our health equity and diversity and inclusion task forces have reconvened and are well underway with their efforts to move this important work forward. I look forward to being able to share with you some of the great outcomes in terms of the recommendations that are coming from those groups in the coming weeks, as well as inviting greater and broader participation in future work, as well as the implementation of those recommendations as they come forward. Now, I'll spend a little bit of time talking a bit about our restoration efforts, a bit of reminders about masking and screening efforts that are ongoing and very important, provide a testing update, and our collaboration with the county. So now, with respect to restoration, this was a big week for us. This week, we restored services in ambulatory care, in dental care, and in system-wide perioperative care and outpatient rehab. While we look forward to restoring further services, it is very important that we remember that changes in key indicators such as our PPE, our general supplies, our staffing, as well as hospitalizations and ICU utilization for positive COVID-19 patients may affect our ability to ramp up services further or the phasing of the ramp-ups. All of the departments should continue to use your daily meetings and your huddles to assess these key indicators and to escalate issues. It really, truly is, and I can't say this enough, a good way to have bi-directional dialogue between our staff. And we have gotten amazing feedback for all the leaders out there who are doing these huddles and continue to do huddles with staff, that you are using them to pass along timely and pertinent information to them. Some that's coming from the command center and some that's more specific to your unit. But also it's providing an opportunity for them to communicate with each other and with you, and you to pass those pertinent needs and opportunities forward to the organizational leadership. So please, please, please continue your daily huddles or your daily meetings and your shift huddles with your staff. The more recent supply dashboard, just posted last night, shows that we are no longer in the red in any of our supplies at present. We received a significant stock of both surgical and isolation gowns in the last week or so, and a large supply of surface disinfectant. And I want to take the opportunity to thank our purchasing team, as well as our supply chain and material management staff, for working tirelessly on behalf of our providers and our patients to source supplies, still in very creative ways, you may be surprised to know, to make sure that we have what we need and when we need it to keep our patients and to keep our colleagues safe. For masking and screening, I just want a few pointers here. As you're aware, Alameda County continues to lead the Bay Area in new positive COVID-19 cases. And even though the restrictions are easing with respect to shelter in place, in many of our cities, COVID-19 is still prevalent in our hospitals and in our communities. The best way for each of us to do our part to limit exposure is universal masking as well as screening. Please remember that when you are to wear a mask, and when you wear a mask, you are protecting patients, you're protecting your coworkers, and anyone who you come in contact with. Masking and personal distancing is required in all of our healthcare facilities, in our public areas, and in our shared workspace. Physicians and staff should use designated screening entrances as you're coming to each of the facilities, and screening is also available in our inpatient nursing units as well as our ambulatory clinics. It is extremely important for the health and safety of our patients and our staff that we continue to adhere to masking, screening, and personal distancing guidelines that we have put into place as an organization. And we received an update from our Director of Infection Prevention and Control today, reinforcing that point. With respect to testing, I'll share that currently AHS patients can receive COVID-19 testing at both San Leandro Hospital and Highland Hospital's HCP parking garage. AHS patients who meet certain criteria, including those without symptoms, can now receive a test with an AHS doctor or another member of the clinical staff ordering, or by calling the ambulatory call center and speaking to a nurse. Expanded access to testing is also critical to our ability to safely restore services, as well as to support our community. With that, I'll say that with our collaboration with Alameda County, we continue to explore ways, really largely under the leadership of individuals like Dr. Hussein, Dr. Turner-Bene, and Dr. Baden, and others. We are continuing to explore ways to partner with Alameda County to expand testing to a broader community, contact tracing, and clinical support at the county's supportive housing locations. So we want to continue that effort. You'll hear more about it, including opportunities that you may avail yourselves of for volunteering and or picking up additional hours and or working in these settings as we formalize the mechanisms by which we'll get this done. So please stay tuned for more of that. Now, before I wrap up my comments and we go to Q&A, I want to do two things. First, I didn't do my shout outs, so I want to go back to that. And I only have two this week, so please send me more if you have them. But one really came from those of you who work in our organization, and it was another shout out to our EBS staff across all of our facilities. I really appreciate that the clinical staff and the administrative staff really are highlighting and underscoring the really important work that our EBS staff are doing and the wonderful work that they're doing to maintain the cleanliness and the safety and the sterility of our environment. So that was one group. And as we sort of turn the tides or turn the clock a little bit, a couple of weeks ago, I did a shout out to our graduating residents who are moving on, whether within this organization or continuing their pursuits outside of the organization. Today, I want to issue a shout out and a hearty welcome to our incoming residents across the organization. I had the opportunity to extend a personal welcome to them earlier this week as a part of their orientation efforts, and I just want to do that in this forum as well. So now I want to turn it over to Tangerine Brigham, our Chief Administrative Officer for Population Health, to share a few words about how population health initiatives in our organization are supporting public health efforts in dealing with this pandemic. Tangerine.
Great. Thank you so much, Delvecchio, and nice to speak with all of you virtually. So I want to first start by making sure we're clear about the distinction between public health and population health, and how COVID in many ways has resulted in both of those overlapping in a significant ways and has required us as a delivery system working in concert with our public health department to really address some of the underlying issues that we see in our patient population. So when you think about public health, I think it's really important to think about it as, you know, the entire community, all of Alameda County, all of, you know, California, and the things that we do to promote public health, be it either clean water, disease control. You know, those are the things that are really public health that affect us every day. You know, population health, which is really what we do in our delivery system, is really focusing on those patients that we see, looking at their clinical data and trying to figure out how we can help them by promoting more preventative care and primary care so that we minimize the extent to which they seek emergency services or high-cost services in our delivery system, and more importantly, how we partner with community-based organizations and social organizations to address some of the underlying conditions. And what we see in COVID is essentially that many people who have contracted COVID and have underlying chronic health conditions have higher mortality. And we know that in our population, which is primarily low income, that those populations are particularly susceptible to mortality and to illness. And that if we as a delivery system are to affect change, we really have to work with other organizations to address the root cause. So it's not simply about providing them with clinical services when they need them. We absolutely want to do that, but our role is not restricted to that. We need to really focus on some of the social inequities, and that's what we're actually working to do with our partners. So I wanted to give you a sense of how we're doing that. So you heard Delvecchio speak about a moment ago housing. You've heard us in various CEO chat sessions speak about housing, and that is critical. And that's because in some ways, while the COVID response of social distancing and sheltering has certainly helped stem the spread of the disease, it has also contributed to some of the underlying conditions that people face. If someone is low income and they're trying to shelter in place, they may be more at risk of food insecurity, which contributes to their poor health status. So it is unfortunate that some of the responses also contribute to some of the challenges that we see in the healthcare delivery system. So in going back to the area of housing, we have focused clearly with and strongly with our public health partners in the Healthcare Services Agency to work with them to identify patients who are eligible for housing, be it either homeless patients, be it those patients who are in our inpatient facilities. They cannot self-isolate at home for a variety of reasons, and so there are hotels available for them. So housing is one of those areas where, as a social determinant of health, you know, it's critical that we partner with community-based organizations. Most recently, I wanted to let you know that just this month, we have started to receive from our county partners social services data for our patients. We partner with the county on a project that you may have heard of called the Community Health Record and Social Health Information Exchange. It's a process whereby we provide data to our county partners, health data on patients, so that they can serve them better if they should wind up in a social services organization. Likewise, social services is now providing us with information on those same individuals. It's a very small subset of data, but that data has been valuable. So we know, for example, which of our patients are receiving CalFresh and which aren't. I can tell you of those patients which ones are receiving IHSS services if they're elderly, and which ones aren't. That kind of information is critical because we can turn that information over to our care management team and our complex care management staff and care transition staff to find out and advocate for those individuals who are not in those programs to get enrolled so that they can get access to those services, because the extent to which we improve people's social conditions, we will by definition improve their health status. And so those are some of the ways in which we are working with community-based organizations and the county post-COVID to improve health status within a broader population health and public health framework. Thank you.
Thank you, Tangerine. And as you, I really appreciate your leadership and work in this effort, along with all of our staff who are helping to support this work. As you alluded, so much of what determines the health status of the members of the community we serve happen outside the walls of our hospitals and even our clinics. It really happens in the community, and the extent to which we are aware of those various challenges as it relates to social determinants or gaps, as they were, better informs the care delivery that we offer, as well as the support that we do upstream to keep people from having what we refer to as avoidable admissions or hospitalization. So I know we're doing stuff in the food insecurity space, as you mentioned, also in transportation and a host of other areas. And we look forward to expanding those efforts and continuing them, and particularly with an eye towards equity and diversity for our patient population as well. All right, well, so with that, Terry, I think we'll turn it over and we can open it up for our Q&A.
All right, thank you everyone for your remarks thus far. As a reminder, if you have a question, please click on the Q&A icon at the bottom of your screen, write your question into the format there, and we will try to answer as many questions as possible as we go through today's meeting. I'd like to start with a somewhat of a broader question. Maybe this will go to Janet and Rachel, and it's regarding Santa Clara County. I think it was early last week, made some requests or directions or demands, I'm not quite sure the weight of it, that providers begin to extend their level of testing to make it broader, test more people. Do we know if anything similar is being contemplated here in Alameda County? And secondly, what would be the overall benefit of taking that action?
I'm happy to take this one. So I just want everyone on this call to know that we are working every single day to expand our testing. And it's definitely a priority for us, not only for our community, but for our workforce as well. It's just a matter of what we can reasonably operationalize at any given time. So there will be a stepwise progression of expanding testing. As everyone knows, we made it a priority in the last several weeks to expand our testing of outpatients and be able to offer that very important service to our community, symptomatic outpatients, and then we expanded it to their household contacts as well. And we're in the process of expanding our testing now so that we can get our operative services and other procedural services up and running. And then when that is done, we will move on to the next phase of testing expansion. So I can assure everyone that this is on our mind and something we're actively working on every single day.
Great.
I think that's great. I'll add to it, and Janet, you can as well if you have more. Thank you, for Rachel. I think that's a perfect synopsis of what we're doing internally. To the question about if there is a similar thought in Alameda County as Santa Clara, I know the motivation is similar in Alameda and Santa Clara, and that is that all of our counties are trying to expand and get up to a greater number of testing in our community broadly. And so what Santa Clara has done is one effort to move in that direction. To my knowledge, Alameda County hasn't indicated an intention to move in that direction. I think the makeup of the hospital infrastructure in Santa Clara varies or differs a little bit than it does in Alameda County in terms of the types of institutions and whether those institutions have the capacity to do testing and are engaged in doing it. As we've mentioned on this call, and as Rachel just said, we are doing a lot of testing in the organization, but are continuously looking at how we expand that testing and do more. One of the differences between hospitals and community-based testing is we all are looking at both capacity in terms of the amount of testing available in terms of kits and the other piece, but the other is turnaround time. And so that's how quickly we can get a test to a lab to be run and resulted and given back. And so in a community setting, a turnaround time of 2 to 3 days is a bit more acceptable than it is in an inpatient setting where a patient is still considered a person under investigation. You're using various amounts of PPE, and you're taking additional precautions. So the need and the acuity of the patient, they're already sick and in the hospital, and so there may be a need to provide additional care, and you just need a timelier turnaround. So we've had to be confounded by the notion of expanding testing and having the calibration of making sure that as we're doing more asymptomatic or even symptomatic community-based testing, that we can segregate that turnaround time and not impact or adversely impact the pace of the turnaround time that we need for people who are in our emergency rooms or in our hospitals. So we're gradually calibrating that. I'm happy to say that under the leadership of Dr. Ng, our lab has continued to move even closer to our ability to do testing and resulting in-house. So we're about a couple of weeks out from being able to do that, and really excited about that as an expansion of our capabilities. And as Dr. Baden mentioned, a lot of leaders are working very diligently, whether clinical or administrative and nursing and others, to expand our ability to support the testing in-house and keep doing that through subsequent phases. So more to come on that, but great work so far. And we're pushing hard, just be clear about that. We're pushing very hard.
Great, thank you. And a related question, when do we anticipate testing all AHS healthcare providers or workers? Do you see that on the horizon soon, or what might be the process to get it to that point?
We have a few steps to take before we make it to that point. I think it's our ultimate goal to test anyone and everyone who would like a test ultimately, but I think we'll be sure to let people know when we expand testing for healthcare workers, but it's not something that is on the imminent horizon. We are able to offer testing though to any symptomatic healthcare workers, and that's available again. If people can't be tested through their PCP, you can email employeecovidssymptoms@alamedahealthsystem.org and seek testing through our urgent care clinic. But again, you need to facilitate that through the email.
And I'd add to that, as everyone knows, we have services in multiple parts of the healthcare continuum, and our skilled nursing, who's been doing a wonderful job at supporting patient care as well as safety in that setting. And so there are new regulations around employee testing in the skilled nursing setting that we are adhering to, along with our surveillance testing for our patients in those settings. And where we have had any situation where there has been the likelihood of a significant exposure in the work setting, we work very closely with employees and employee health to screen and test as necessary in those settings as well. But to put a finer point on what Dr. Baden just said, if you are a employee who's symptomatic, we are offering that testing right now. We're still working through the logistics and the details around how to expand that and make sure we do that in a safe and sustainable manner.
Great, fantastic. We have a number of people on this panel who also serve on our Restoration Oversight Committee. And there's a question about how are patients being tested prior to coming in for some of the reopened services, GI, surgery, dental. What's being required of the test, and what happens if they receive a negative result? Any one of our ROC members want to take a shot at that particular question?
Yeah, I'll answer that. So all those services except GI have been stood back up. So surgery started on Monday at all 3 campuses, Alameda, San Leandro, and Highland. Ambulatory was open, dental was open back up. The test is ordered by the surgeon that is performing the surgery. The patient drives through. They can either drive through Highland or they can drive through San Leandro. Those tests then track back to that surgeon. If the test came back positive, they would reach out and contact the patient and cancel that surgery and then reschedule for another time. If they're negative, they would know that. Having said that, patients are tested a number of days before surgery. On the day that they come in, they are not tested again, but they are screened again. And so should they come with any of the positive screenings, they would look at that and then potentially cancel the surgery as well. But everything started off well on Monday. We continue to, it's only Wednesday, but show very positive results from the testing that's been stood up, from the processes that have been put in place. I haven't heard any real issues at all. So we'll get better as we go forward, and we'll add more cases to the roster, but right now it seems to be working really well.
Great. Thank you, Janet. Andrew, would you like to add to that?
Yeah, sure. I'll just add in on the ambulatory side, as Janet has mentioned. Each service line is slightly different depending on, sort of the PPE needed or the clinical scenario. But in ambulatory, still our leaders there are still looking at what visits can be done telephonically or virtually. That's still, sort of our continued future model, how we can provide care to patients in the place that's easiest for them. But there are going to be patients that are going to need in-clinic care. So for those patients, the ambulatory team has come up with a pretty extensive playbook that is something like 25 to 30 pages, which includes pre-screening by the patient services representative for symptoms, another screening of the patient does when they come in, and in instances where the patient absolutely needs care and there's an opportunity, but it's not urgent enough that the patient can be tested, those patients will be tested. And if there's an urgency that the patient needs to be seen, the decision that the provider will make is whether or not that patient needs to go to the ED or come into a clinic visit. And if that's the case, whether it's a positive patient or a PUI, there's strict protocols and guidelines around PPE, around how to take care of those patients. But again, priorities are number one, continuing telephonic virtual visits as much as possible, then stratifying those who urgently need to be seen, ask whether they need to be tested, and if so, do they go to the ED or come to clinic? And the final thing I'll just say is that in dental clinic, recognizing a slim fraction of patients that need to come for urgent procedures, we recognize as a higher rate of possible transmissibility. And so they have actually face shields and other masking for added levels of PPE. So each of the leaders who have submitted proposals have completed a 108-step checklist, and it's been a highly collaborative process with our ID docs, infection prevention, or service line leaders. And included in that is training and protocols for you who will be delivering the care, so that you have an opportunity to feel comfortable about it as well. So yeah, I don't know if others have to ask, but I've been very proud by our leaders and the work that they have done from my perspective.
Thank you, Tanvir. Yeah, the only thing I'd add is, in addition to that kind of amazing group of folks who come together to do this exhaustive work, which we so very much appreciate, is our STAR team, who's really been helping to work with each of, just about, I think, all of, if not all of the groups to go through that process, sometimes daunting, sometimes frustrating, but all done in a spirit of how do we do this as safely as possible for everybody involved. And so we very much appreciate that.
Thank you. There has been a lot of communication that has gone out over the last few days regarding masking. And there's a question here, and it's this, I'll just put it out there. What is the correct mask to wear inside the hospital, or what is considered a universal mask? See, that's why we have, that doesn't look anything like mine. I don't know what that is.
We're all doing a show and tell right now. This is awesome. Rachel, you want to say anything more?
Yeah. We are asking that while you're in the hospital and you're at work, that you wear these surgical masks, these masks that we have distributed widely, of which we have ample supply in order to offer everyone. And you not wear your masks from home while especially while forward-facing in terms of patient care, et cetera. And the reason for that is that there are lots of different masks that are out there. Not all of them are the same. Not all of them offer the same level of protection. but we feel confident in this mask and want everyone to don this while at work. I pass many people in the hallway and they're wearing their masks like this. This is not effective. My favorite is the chin. This is also not effective. And then it's also not okay. Sit down next to your coworkers and remove your mask when you take a break. Okay, we really do want universal masking. So that means wearing this all the time. If you do need to take a break, you need to either eat or have something to drink, please do so in solitude so you're not exposing others, at least 6 feet from others, but preferably all on your own. And you can remove your mask for those instances. But this is the mask we want you to wear, and we want you to wear it over your whole face, please.
So that being said, I just want to make sure that people are comfortable that should they need a different mask, whether they're in a patient room doing a procedure or, there is the recommendation of an N95, we also have those masks available. So we have all the PPE that's necessary to keep patients and staff safe. This is just the recommended mask for everyday use, but we are not saying that you can wear that mask, a different mask when it's appropriate.
Right. And we should have enough to supply you one once a week, or if it becomes soiled in the interim, just ask for a new mask. But yes, as Janet says, should you enter a room where a patient is a PUI or a patient is on airborne precautions for other reasons, you do need to don an N95 mask in that instance and doff it, throw it away after that encounter, and re-don your universal mask.
Okay. A follow-up to that, for those of us who are working outside of the hospital, SSC, Fairmount Administration Building, are there different masking guidelines we should be thinking about? Are there different masking requirements? Like this one that I have doesn't fit that category.
I think we've been explicit in saying we want you to wear these universal masks, and specifically, definitively in any patient care areas. I believe our masking policy allows for a little more leniency in terms of masking in non-patient care areas. So the SSC would be one of those instances where perhaps you could don your mask like Terry's, which is from home. I believe that was the distinction. So if you are in definitively a non-patient care area and you're not around people who are providing patient care in any way, then certainly any facial covering is appropriate.
Great. Thank you for the clarification. If folks need more information, there have been newly posted materials on the COVID-19 resource page with great illustrations for our visual learners. If you didn't get the visuals from our group today about the proper way to don and doff your mask. So please check that out if you have any questions about this moving forward. Great, thank you. Tangerine, your response and the scope of work you're doing in population health was very welcome. They have I think this is going to be like a $50 billion question for you. You may not be able to answer it, but I'll send it your way anyway. As you know, the hospital systems across California, I mean, they're estimated losses in the tens of billions of dollars. Governor has requested some support from the federal government in order to manage the state budget situation. But the question is, do we anticipate possibly getting additional support from the county or state to help subsidize some of our population health services that we're currently providing?
So, well, first let me say that the county actually does currently subsidize some of our population health activities. So, for example, some of you may have heard of our Health Advocates program. That program funds when we have volunteers that assist our patients with connecting them with social services, be it either housing or immigration services, legal services, IHSS, and the like. And the county funds that. The county has funded and given us dollars for transportation for our uninsured population. So, and certainly the county has funded medical respite. So the Adeline Respite, which is a facility that we use for individuals who cannot be discharged safely to their homes, but don't require being on the inpatient setting. And so they need some recuperative respite care. The county funds that on behalf of AHS and its patients. So the county is currently doing that And we're really appreciative of the support. They have not indicated that they're going to discontinue that support for our delivery system. Now, the county has received, like all counties have received in California, additional dollars as a result of the various stimulus packages. And the county is looking at how to appropriately allocate those dollars to address a combination of clinical needs, social services needs, and just economic losses throughout the county. And so we will currently work with the county on those particular efforts, but I certainly do not believe that the county would abandon their support for the range of services that they recognize that our patient populations need outside of medical care.
Great. Thank you. There's been a lessening of some of our shelter-in-place protocols. We're opening up businesses and services throughout our communities. We had a Memorial Day holiday recently passed. Folks have been out in recent weeks demonstrating. We have 4th of July coming up, vacations and folks needing to get to the beach and the like. Have we seen thus far any spikes in positive tests here within our system, within the county? And is that more related to doing more testing, or can we ascertain if that's related to some of the lessening of activities?
I can answer this one. So we continue to see a rise in cases in Alameda County, and that's been fairly consistent. That is both due to expansion of testing and likely also increase in cases as well. We saw a spike over, I would say, starting around 2 weeks ago in hospitalizations that seems to be downtrending at this point. And I think we're experiencing that same trend here as well, although the last 24 hours have been pretty busy with COVID cases here. But what I saw was that over the course of the last week, our number of cases here was going down compared to what it was the 2 weeks prior. But we may be seeing an uptick again based on the last 24 hours. It's been pretty busy. And so we are experiencing the trends here that the county is experiencing. And we meet with the other hospitals in the county, and we consistently at Highland have at least the most cases, if not second most cases of any hospital in the county. So I think we're a pretty good measure of what's actually happening on the county level. So cases are moving in the wrong direction in Alameda County. That is the general message. And it's probably a combination of many things, one of which is the increase in activity that we're seeing around the county, and lack of social distancing and the opening of many things across the county.
If I could add to that too, I think there is a little glimmer of good news here. We are seeing an increased level of PUIs, specifically, San Leandro has really bumped up in the last couple of days. What we're finding is a lot of those are coming back negative. The ones that are positive are not seeming to hit the ICU in the way that they were earlier. And so our number of vented patients is way down, and our number of ICU patients is way down. So I think people are turning up positive, but their symptoms seem to be a lot less. And I think we're able to send, every morning I look at the number of PUIs in the ED, and the vast majority of those patients are sent home to wait to see what their test comes back like. So I think that's a very positive, numbers might be going up, but the acuity seems to be dropping down a little bit.
Yeah, I think that's actually multifactorial. I think many of us are wondering if some of the interventions that we have in place to treat patients are starting to make a difference in terms of their outcomes. We are seeing a lot less transfers to the ICU. So our ICU census is fairly low actually for COVID patients across the system. And so that is great news for us and great news for our patients. It's a question of whether the patients are just not as sick when they present, which is the case. We're sending a lot of patients home, but also maybe some of the interventions that we do have and the treatments that we do have available are making a difference. And I think it's too early to tell that, but the general gestalt, or anecdotally, many of us are feeling that that is the case. So that's the good news. And we haven't had, I'm knocking on some wood here, we haven't had a patient succumb to COVID here in several weeks. So overall, our mortality data here is quite good, actually, comparatively. We've had really generally quite amazing outcomes.
Yeah, I'm glad this is all really, really helpful information, Janet and Rachel. When you went to the mortality, can I ask a question? I know early on the all but for a while all but one of our mortality were connected to patients who had DNRs. So our ability to use the more invasive measures to support them was in some ways impaired. Is that still the case? On balance, have most of them been patients with
I think
DNR orders?
yeah, we haven't had a death in a few weeks now. So our numbers have been holding steady at 14 deaths in our system from COVID. The last few ones that I know of succumbed to the disease just from fulminant ARDS and multi-system organ failure. So I think it runs the gamut, but we did have many patients, especially early on, who didn't want more advanced interventions and chose to become what we call comfort care only as a result of their COVID. So it's hard to really understand our mortality data. Our actual outcomes because of that may actually be even better than we think. So, so I think that is one positive. We have amazing intensivists in our system and unbelievable ICU care in our nurses across the system. So I'm really proud of all of our ICU teams and the level of care that they're able to provide.
And our RTs as well, right?
Yes, and our RTs,
Yeah.
anybody, our RTs, our nurses, our intensivists, you guys are awesome.
Yeah, thanks for that, Rachel. I wanted to jump in and just say, nurses across the system, despite the level of care, whether you're a med-surg patient or an ICU patient, we couldn't have had the good outcomes without everybody jumping in and helping. I think we've had a number of stories where nurses have kind of taken it upon themselves to say, this guy is going to go home. He is me. I get it. He's going to go home to his kids. And so they've really taken a personal approach to make sure these people have the best outcomes. So thank you to everybody, no matter where you are, EVS for keeping the place clean, nurses for delivering care, physicians. We all have a role in this and everybody deserves to be thanked.
We have to acknowledge our ED teams and also our hospitalist teams as well, because I think they're bearing the brunt in terms of sheer volume of the COVID cases. But there's been amazing collaboration amongst our clinical teams, and I think we're doing a clinical trial here for maybe the first time ever on the inpatient side, and I've just been stunned by the level of engagement from nursing, from all the physicians, from everybody. So to help make it a success, so it's been wonderful.
All right, that's all great news, great feedback. So Rachel, since you mentioned the clinical trials, can you tell us a little bit more about what that is so that we have a sense of what we're trying to achieve with that process?
Yeah, in terms of let me just give a broad overview of what our therapeutics are. We've heard this before on the call, but just to review, we have an antiviral that works directly on the virus called remdesivir. We currently receive remdesivir through the county, which is from a federal allotment. We hope to continue to receive this for the next few weeks, but it's been wonderful. We've had enough supply to provide it over the last several weeks to any patient who is qualified for it. So that's been tremendous. The other therapeutic that we potentially have available to patients is called tocilizumab, which is something that works on your inflammatory response, so that your body's response to the infection, which we know seems to contribute to the disease and sort of the pathogenesis of how COVID works. And so tocilizumab shuts down one specific part of your immune system called your IL-6 cytokine by working on the receptor. And we have a randomized, controlled, double-blinded study to evaluate tocilizumab in the setting of COVID pneumonia. And so patients are either randomized to receive tocilizumab or placebo. We do not know. And to date, we have enrolled 4 patients successfully who have all been doing fine. We've discharged one of them already. Spoke to him last week and he told me he felt perfect. So I don't know which drug he received, but he did well in the clinical trial. And we're in the process of enrolling maybe our 5th and 6th patient today. So things are pretty busy, but it's been amazing to see the collaboration across the system. So we can offer this trial both here at Highland and San Leandro Hospital. We also have been offering in sort of refractory cases when we've tried to use all other options, convalescent serums. So this is plasma that's been donated by patients who have recovered from COVID with the idea that their antibodies or their immune response to the virus is present in their plasma, and then we're transfusing it into patients who are suffering from COVID. So we've done that in a handful of patients across the system successfully as well. And there are newer data that maybe you read in the press in the last few days about the use of steroids in COVID. And so our medication committee will be reviewing all that data tomorrow and come up with a statement for the system on the use of dexamethasone in the setting of COVID as well. So everyone can look out for that as we review and come up with some guidance around that.
Great. Thank you, Dr. Baden. Maybe Tony and Delvecchio can speak to this next question or topic. There's been some changes within our interpreter services over recent weeks. Wondering to make sure that we're aligning our services with the population that we serve. That's resulted in some impact on some employees. Can you speak a little bit about the purpose of what we're trying to achieve with the changes in interpreter services, and what has been the result of some of the findings that we found when we looked at how our services were lining up with our patient needs in interpreter services?
I can come off mute first. I can deal with that, Terry. So over a long period of time, we've been analyzing the number of calls related to specific languages and the need of our interpreters to clearly then interpret those languages for patients. I think as part of our normal course of business, what's been identified is we have a couple of languages that are almost never used, and we had more interpreters than we needed to deliver service to those patients. What that also means is we have larger demand in certain languages, Spanish being one of them, where we may need additional support. And so what the department has done is rebalance the skill set of the interpreters. The consequence for humans here is that there's been a reduction in force in that department. What I want to be clear on is unrelated to COVID or any other plan around that. It's been an assessment of the business need. And by business need, I mean the demand of our patients. What languages are needed by our patients so that our physicians and other care providers can speak to them in the language that they need to be spoken to when they're receiving care. The focus is to balance all of our patient needs with what we are able to deliver internally. And a couple of languages, we had highly skilled interpreters or people who were able to work for us, but the demand in terms of total calls was incredibly low. That's no fault of the individuals. They did nothing wrong. There was nothing related to them as people or the services they delivered. It really is the demand of our patients in specific languages, and the team was rebalanced to address the needs of the patients overall. That unfortunately impacts these individuals. Whenever this happens, our first goal is, can we accommodate these people somewhere else in the organization? Can we find them alternative employment as part of the broader AHS family? In this instance, I don't know the answer to that yet. We're working through the process. They have a very specific skill set. If we can accommodate them somewhere else in the organization, we will. We work through that process with the individuals and the unions. And obviously, it's never a great thing when people are impacted like this. But where I want to really be clear to our employees that are on the call, the focus of this was a change in demand from our patients. It did not relate to COVID or any impact from that perspective. So let me stop there. If you want to add anything.
Not a lot, Tony. I think you handled that nicely. And I just maybe pick up on your last point there that you're underscoring, which is as an organization, we have not made any COVID-19 or pandemic related adjustments in our workforce in terms of layoffs or terminations of that nature. And to that end, what I'd share is, as I think everybody on the call probably knows or should know, that we are ending the fiscal year that we're currently in and going into a new fiscal year that starts July 1, which is generally meaning that we're ending one budget cycle and starting a new budget cycle. We've been in the budgeting process for the past few weeks here. We are impacted in our ability to complete our budget because of so much uncertainty and so much unanticipated impact at the end of this year here that is now filtering into next year. Because of that, we've been having ongoing dialogue with our board and with other stakeholders to say, you know, we are continuing to work internally, but also need to work externally to understand the ramifications of what we are experiencing here and what we need to do. And on this call, we've talked a little bit about kind of our thinking there and committed to bringing back to you all an understanding as we get it of what's happening going forward. And I'll tell you at this juncture, what's important for people to understand is that we've been talking to our board, we're giving them updates, and their message to us has been, let's look at, as we would any year, all of our ideas for improvement. Are there new things that we can bring on or expand within the organization that are consistent with patient demand and need and our resource availability that would help us to retain jobs and to commit or align that with the care needs of our patients? Similarly, are there opportunities for efficiencies in the organization, meaning are there costs that we are carrying that by virtue of changes in the way in which we do business or changes in the broader market that we can leverage to manage our costs, and in many cases cut those costs. But the board's mantra has been, we want to preserve jobs. As best we can, we want to preserve jobs, and we don't want people to lose their jobs as a result of this pandemic. So as we're going into the budget, that means a number of things. It doesn't mean that it means we'll be looking a lot on the non sort of staffing or labor side of our shop, which is only a small portion of our budget, but looking at where we can, cut costs with contracted vendors, be more efficient in our use of supplies and other resources so we can cut costs there, and a host of other things. On the staffing side, it may mean things like we're looking at what do we do with cost of living adjustments or increases, incentive programs, or any other sorts of things that may maintain a salary with a market, which we would ordinarily do and would want to do just to be a responsible employer. But by virtue of the challenges we may face, some of those things may not be readily or as readily available to us. Now, because of the various labor environment that we operate in, we have to talk to our board to figure out what does that mean, how do we work with our various unions, and for those non-unionized employees, a lot of our, some of our administrative staff, some of our executive staff, a lot of our providers, though not all, how do we work with that population as well to say, how do we make sure that across the board we are looking at all the ways in which we can manage our expenses, work through the challenges that we face, but preserve the services and ergo the jobs and the people who provide those services consistent with the community need as it too has evolved and is evolving. So that's all I'll add. And so that work is still ongoing. You will be hearing more from our leaders soliciting, and I'll put a plug in now, ideas, improvement ideas at the local level, at a system level where we can actually avail ourselves of those things to again, help our patients, preserve our services, generate more revenue, and continue to sustain the organization. And then we'll be working with your leaders at either the site-based level or the unit-based level or departmental level to look at those opportunities for efficiency as well. So anybody having additional questions about localized impact or implications and or your great ideas, please work with your managers, your directors, your VPs, and let's solicit those ideas and get that bidirectional communication continuing and ramping up as we go through this process.
Great. Speaking of those folks who help us serve our patients, volunteers. They've been absent from our facilities for a while. Any sense of when we might be bringing volunteers back and what might be some of the considerations that will need to be thought through before that happens?
Yeah, thanks, Terry. So Jason Piccone, who's the manager of the volunteers and then reports to Jessica Pitt, has developed a business plan that will go to Tanvir and the ROC committee to make sure that we can reintroduce volunteers safely. It's not the same across the entirety of the organization. At the two community hospitals, they're predominantly auxiliary. And so by age, they're older than the volunteers who are typically here at Highland or in the core of the system. And so there's a higher level of risk. So we're assessing the risk to the individuals who would volunteer. We look at the locations that those volunteers would go to, any additional PPE we may need to support them being on site, limit the risk to them, and most importantly, the risk to our patients. And so that's being developed. It'll go to the ROC committee and we'll work out how we can reintroduce them. Like all other services that are being reintroduced, we're doing it in a staged fashion. Moving multiple people back at the same time could potentially overwhelm us just on the demand side because we've had a number of people working remotely, reduction in services, and bringing lots of people back onto our site is by itself going to increase the demand on our PPE. So we want to be very thoughtful about this, and we're working our way through that process right now. So I don't want to put a deadline on it because it's dependent on variable factors. but the plan has been developed. It will be going to the ROC committee for their review and assessment about whether it fits. And once we've decided how and when we can reintroduce them, we'll be able to share that more broadly.
Okay. Thank you, Tony. Tanvir, I'm going to toss this one your way. We are, I think, 2 weeks deep into the Joint Commission survey window possibility of showing up, surprising us, and any day now. Any thoughts of where we are in terms of preparation for the visits? Any suggestions you might want to share with folks to prepare themselves for the eventual visit when it does occur?
So, have a reflection. I think people at this point will not be surprised. And the reason is because as I round, and I know the leaders around, there's just been really persistent, dedicated, conscientious effort to make sure we're in this continuous state of readiness. And I want to take a moment to acknowledge that. I also want to take a moment to acknowledge what feels like a true opportunity that we've tapped into for cultural transformation around quality and safety, which is that we all feel that it is the right thing to do to speak up when we see an opportunity to improve a process to make things safer for our patients. Because wherever we see an opportunity where we can intervene, and that's an opportunity of prevention that doesn't affect our patients. So that is not something that's been happening by luck. It's just been a really committed effort by each of our frontline staff, our physicians, as well as continuous reinforcement from leaders. So I also know that when we're in the midst of that sort of transformation, there's periods where it feels exhilarating and exciting, particularly when we see the impacts of how our patients do better, how our space is transforming. But I also know that at times that gets exhausting. So I say to you, keep it up, rely on each other when you feel moments like it's getting exhausting, because we have each other to support through that. There will definitely be this deep sense of relief when the Joint Commission comes for their resurvey, because it will be an opportunity for us to demonstrate what it is we've achieved. And so I assure you that the quality team is also keeping in touch with the Joint Commission to see if they'll give us clues about when they're going to come. So far, we don't have any yet. I suspect that some of the delay were related to the suffering that our country was facing around the protest, and I think they're recalibrating about and trying to be sensitive to communities, COVID, and then the protests. But keep it up. I'm hoping that they're going to come in the next few weeks, and then we begin our work with sustainability. As part of that readiness, there's a checklist that you all are doing, everyone is doing, and do keep in mind that when they do come back, they are going to, like you have all asked, they will also be asking, is everyone wearing the appropriate mask? Are you doing hand hygiene? Are you getting screened? As you know, in our local community, we had an outbreak at one of our sister hospitals where we learned through our public health leaders that some of the things that as the pandemic has been going on, sometimes so too do the deliberate practices begin to erode, like masking, like screening, like being careful about when you're in shared spaces. So get screened. If you're not at one of the facilities like San Leandro or Alameda, where there's not a single point of entry, and you're able to bypass that at Highland, make sure you get it done on your unit. If you don't know where to get screened, please ask today. Please find out where that's happening. It's not for the Joint Commission, it's for us and it's for our patients. So keep those things in mind. If you have questions, ask. If you see something, voice it, and know that we have each other to keep our resilience up, and just a tremendous, great gratitude to all of you.
Great, thank you. We are getting close to the hour. With that, Mr. Finley, if you would like to extend the last word to our listeners, that would be great.
Well, I just want to thank Tanvir for those very comprehensive and great remarks, and really just want to underscore all of it. And yeah, one thing I will say, and it's sort of part of my wrap-up remarks anyway, but it is, the stress can really take its toll on people, and it's just not necessarily even like the taxing nature of it, meaning the heightened element of it. It's just the persistent nature of it sometimes. And so I think there's some things we can do psychologically, both individual and with each other, that can help with that. I mean, I think we should channel channel this. Stress or anxiety related to survey readiness is about the second part of what he said. It's sustainability. So this is about, surveys are kind of window dressing. This is who we are and who we want to be at all times. So it'd be nice to see them, and it'll be nice to show them what wonderful work you are doing. But that's it. It's really just to show them. And when they leave, we'll be doing the exact same work they're doing today. So the stress shouldn't be there. Let's turn this into positive reinforcement. Ask people, yo, let me see your best. Did you get checked today? Show it off. This is a badge of honor, I think, to say, I'm protecting you, I'm protecting myself, I'm protecting our patients. So don't mind asking people. And if you're getting a negative response, let us know, because that means that there's an element of our culture we still need to continue to work on, and we will do that. So it's a bit of a different end than I normally do. I know we're at time here, but I do want to say, as I do always, take care of yourselves, take care of each other. Look out for our Wellness Wednesday remarks. Today's about self-compassion, and so you should look at that one as well. And with that, I know we're at time. I thank all of my co-panelists. You're always wonderful, and I learned a lot from you, as I know everyone else does. And thank you for your great questions.
Right. Thank you, everyone, for attending today's desktop chat. Please be reminded that the chat will be posted online for you to review or check out at a later date, or others who may not have been able to join us. So we thank you again for your time and your great questions, and we'll see you again soon.
Bye.
Bye.